Then we have the effect of the site of infection on the therapy or the blood-brain barrier. So this means that the nature of the drug which you are going to be prescribing to the patient would also be determined by the site of infection. So as you know that the main purpose is that the adequate levels of the antibiotic must reach the site of infection. But this is, you can say, most important in the cases where the tissues are offering the natural barriers. For example, you know that in the tissues of the prostate, testes, placenta, and we have the vitreous body of the eye, and most importantly, the brain, in which what we have is the blood-brain barrier, which is formed by the single layer of the endothelial cells and which are fused by the tight junctions. So those tight junctions are impeding the flow of the, you can say, virtually all the molecules from the brain, from the blood into the brain. So in this way, that can lead to the failure of your therapy if those molecules couldn't get entered into the blood brain barrier, which it was meant to. So determining the site of infection is also very important when we are initiating a therapy. However, the molecules can enter into the CSF. It would enter when the molecules would have these properties, okay? So let's discuss the properties one by one. First, we have the lipid solubility. So the lipid solubility should be increased. The more the molecule should be more lipid soluble to get greater entry into the brain, or you can say greater entry through the blood-brain barrier. So, for example, the chloramphenicol and the metronidazole, they both are lipid soluble drugs, so they can get a sufficient entrance into the CNS. Whereas the beta lactam antibiotics, in which we have, for example, the penicillin, so as its lipid solubility is less, that is why it can get the, you can say, it has the limited penetration through the blood brain barrier under the normal circumstances. But yes, when there is an inflammation of the brain, they can get the greater entry into the brain. Why? Because as there is inflammation of the cells which are present in the brain, so that would allow the improper functioning of those cells. So it means that the blood brain barrier, it is not much efficient, so these molecules now can escape through the blood brain barrier. So it means that in the meningitis, these drugs can easily penetrate into the CNS. But yes, we have another property as well which we have to consider, that is a molecular weight. So only the drugs that are having the low molecular weight, they are going to penetrate the blood brain barrier. So lower the molecular weight, the more is the ability to cross the blood brain barrier. Like here we are given with example of the vancomycin. So this drug has greater molecular weight, and because of the greater molecular weight, it cannot have even the good entrance in the inflammation of the brain. So it is going to penetrate poorly even in the presence of the inflammation. Then we have the protein binding. In order for the molecules to get more entrance into the brain, they should have the decreased protein binding. It means they should be in the unbound or the free state. Then we have susceptibility to transporters or the efflux pump. For the better penetration into the CNS, in this case, the molecules should have the better susceptibility to the transporter, so that they can get more bound to the receptors and they can get entered through those transporters, or you can say they can cross the blood brain barrier easily. But they should have poor affinity to the efflux pumps. Why? Because if they would bind to the efflux pump, they would be pumped out. That is why. Then we have the patient factors. So what we need to consider in this case, yes, we must consider the condition of the patient. We have to look at the status of the immune system of the patient, the kidneys, liver, circulation, age, and in the women, we have to look for the pregnancy or the breastfeeding. So, okay, let's discuss these things one by one. We have the immune system. Now, as you know that the efficient immune system is required for fighting off the microorganisms from a body, and if it is compromised because of any factor, like we have the alcoholism, diabetes, HIV infection, malnutrition, autoimmune diseases, pregnancy, advanced age, or any immunosuppressive drugs. So for in these cases, we have to take the higher doses of the bactericidal agents, or we have to go for the longer courses of the treatment in the immunocompromised conditions. Then the renal dysfunction. So renal dysfunction is also a main concern, because if the kidneys function is poor, then the drugs are going to accumulate. Okay, and then we have to adjust the dose. And this dose adjustment is basically determined by the serum creatinine level, which is taken as an index of the renal function. And that was all about it. Then we have the hepatic dysfunction. So in this, definitely you know that all the drugs that are basically being metabolized by the liver enzymes, so they will not be metabolized if there's any dysfunction of the liver, or if you are taking any other drug which are inducing the enzymes or which are inhibiting the enzymes of the liver. So these are going to be the effects. Then poor perfusion can also be a problem, because if the circulation to the affected area is not good, so the drug which you're using to treat that affected site would also not reach that site of infection in a sufficient amount. So that would result in the poor healing of that area, or you can say the treatment would be very much difficult. Then we have the age. So for example, in the newborn, as you know that the renal and the hepatic elimination processes, they are poorly developed. So the neonates, they are more vulnerable to the toxic effects of the agents, like we have the chloramphenicol or the sulfonamides. So these drugs would have the poor, or you can say the toxic effects on the newborn. Then okay, in the age we can also see the young children. So in the young children, we shouldn't treat those young children with the tetracyclines or the quinolones, as these drugs, as you know, that they form chelate with the cations. Yes, so the tetracyclines, it is very much known to form the chelate with the calcium ions. So these drugs, they shouldn't be used in the young children, as they can suppress the growth of the bone. Okay, so it can affect the bone growth and the joints. Then we have the elderly patients. So as you know, in the elderly patient, the kidneys and the liver function is decreased, so that can alter the pharmacokinetic of the certain antibiotics. Then in the pregnancy and the lactation, what is important here is that the drugs can cross the placental barrier. That would definitely affect the developing baby. And if the drugs would pass or enters into the breast milk, then this is going to affect the nursing infant. Although the concentration of a drug in the fetal circulation and or in the breast milk, it is low, but the total dose can be very much sufficient to produce the detrimental effect, and this can cause the congenital abnormality. So okay, this should also be considered. Then we have the risk factors for the multi drug resistant organisms. So only the thing is that in order to prevent the development of the resistance, you need to treat the disease with the broader antibiotic. Then we have the safety of the drug. So in the safety of the agent, so the safety is also an important thing, and we should always go for the more safe or the most safe drug. For example, the penicillin is considered to be the least toxic, or you can say the most safe drug. Why? Because it interferes with the site or the function that is unique to the growth of the microorganisms. So it means that there are less chances of its function to be overlapped with our function. That is why it would have less toxic effects as compared to the other drugs. And the important point is that this safety is not only related to the nature of the drug, but it is also related to the patient factor. It means that you have to also consider the condition of the patient. Then the cost of the therapy should also be considered. All of the choice of therapy depends upon the site of infection, the severity of the illness, the ability to take the oral medication. But again, you have to consider the cost. For example, if two or more drugs, they are having the same efficacy, then you are going to focus on the cost. Then we have the route of administration. So as you know that we have many different routes of administration, and for example here the oral route It is most appropriately used for the mild infections. Then parenteral route is used when there's poor absorption from the GI tract, or if it is used for the serious infections. Then the switching between the routes can also be done. For example, from the IV to the oral therapy. This is required, and this is oftentimes it is beneficial. Why? Because it can decrease the health care cost, and it can shorten the length of stay, and it can decrease the complications from the IV catheter. Okay, so the switching would also be required in some instances. Then we have the determinants of the rational dosing. Okay, then in the determinants of the rational dosing, it basically depends upon the pharmacokinetics and the pharmacodynamic properties of the drugs. And here we have the three properties on which we are going to determine the rational dosing. So the first is the concentration dependent killing, then we have the time dependent or the concentration independent killing, then we have the post antibiotic effect. So in the concentration dependent killing, you know that the more is the concentration of the drug, the more is definitely the effect of the drug. Then in the concentration independent, it shows that it is not going to depend upon the concentration of the drug. So the efficacy of these drugs is predicted by the percentage of the time that blood concentration of the drug remains above the MIC. So it means that for how long that concentration of the drug in the blood is above the MIC, or the minimum inhibitory concentration. Then we have the post antibiotic effect. So it shows that after the drug's concentration or the antibiotics concentration has fallen below the MIC, even then there is still the persistent suppression of the microbial growth. It means that when the drug's concentration is below the MIC, it is still producing its effect. So that is what is the post antibiotic effect. Then we have the chemotherapeutic spectra.